Lesson 3. Preventing Infections and Communicable Disease. Introduction. Infection Prevention and Control, IPC, affects all patient care activities in healthcare settings and is an essential component of healthcare quality and patient safety. Effective IPC includes building a program with all healthcare personnel, HCP, playing their part to prevent the spread of healthcare-associated infections, pathogens, and antimicrobial resistance. How diseases are transmitted. Infectious agent, a virus, bacteria, or other microbe that is capable of causing infection. Reservoir, where microorganisms can be found. This can be a person, patient, or healthcare professional, or the environment. Environmental reservoirs include dry surfaces, bed rails and medical equipment, wet surfaces, faucets, sinks and ventilators, medical devices fixed into position in a patient's body for some time, catheters and IV lines, and the environment around the patient. Portal of exit. Microorganisms must exit their reservoir to spread. For example, when someone coughs, microorganisms leave the reservoir, the person, through the respiratory tract. Portals of exit can include breaks in the skin, mucous membranes, eyes, nose and mouth, hands, blood, and feces, vomit and urine. Portals of exit can also be splashes from vomiting or an exposed needle in an open sharps container. Mode of transmission. Microorganisms need a way to move, spread, from the portal of exit to the portal of entry. Microorganisms usually depend on people, the environment, and medical equipment to move in healthcare settings. Modes of transmission include direct contact, mainly skin-to-skin contact, but also contact with soiled surfaces, and droplet spread, spray from sneezing, coughing, or even talking. Indirect, airborne and contaminated equipment. In direct transmission, an infectious agent is transferred from a reservoir to a susceptible host by direct contact or droplet spread. Standard and transmission-based precaution measures. Standard and transmission-based precautions are core IPC practices that HCP use to reduce the transmission of microorganisms in all healthcare settings. Standard precautions aim to protect both HCP and patients from infectious agents. They are required in all healthcare settings. Standard precautions are recommended for the care of all patients in any healthcare setting, regardless of their suspected or confirmed diagnosis. Standard precautions include hand hygiene, environmental cleaning, injection and medication safety, risk assessment with appropriate use of personal protective equipment, reprocessing of reusable medical equipment, waste management, and respiratory hygiene and cough etiquette. The type of precaution assigned to a patient will depend on the mode of transmission of the suspected or confirmed pathogen. Hand hygiene. Hand hygiene is a critical component of infection prevention and control. The hands of HCP can play a significant role in spreading microorganisms between patients. Identifying and applying the WHO 5 moments of hand hygiene at healthcare facilities will clarify why hand hygiene must be performed at those critical moments. Understanding how to incorporate good hand hygiene practices strengthens the efficiency of IPC programs. For facilities without running water, low-cost, locally made systems can help ensure water is available for hand washing. Injection safety. Injections are one of the most common medical procedures. They prevent and treat diseases and save lives. WHO estimates that about 16 billion injections are given each year worldwide, but many of them are unsafe and spread deadly diseases like hepatitis B, hepatitis C, and HIV. In some parts of the world, syringes and needles are simply rinsed and reused. WHO recommends that all injections be given with a new, sterile syringe and needle opened from a new packet and have mechanisms preventing reuse. WHO also recommends syringes and needles that protect healthcare professionals from injuries to make every injection safe. Neglected tropical diseases, NTDs, are a group of 20 conditions mainly prevalent in tropical areas, where they mostly affect impoverished communities and disproportionately affect women and children. These diseases cause devastating health, social, and economic consequences for more than 1 billion people. The epidemiology of NTDs is complex and often related to environmental conditions. Many of them are vector-borne, have animal reservoirs, and are associated with complex life cycles. All these factors make their public health control challenging. WHO estimates that over 1.7 billion of the world's population should be targeted by prevention and treatment activities for at least one of these diseases every year. In addition to significant mortality and morbidity, approximately 200,000 deaths and 90 million disability-adjusted life years, dailies, lost annually. NTDs cost developing communities billions of United States dollars each year in direct health costs, loss of productivity, and reduced socioeconomic and educational attainment. They are also responsible for disability, stigmatization, social exclusion, and discrimination. In spite of this, NTDs have historically ranked very low on or been almost absent from the global health policy agenda, only to gain recognition in 2015 with the Sustainable Development Goals, SDGs, SDG Target 3.3. Tuberculosis. Tuberculosis, TB, is a communicable disease that is a major cause of ill health and one of the leading causes of death worldwide. Until the coronavirus, COVID-19, pandemic, TB was the leading cause of death from a single infectious agent, ranking above HIV/AIDS. TB is caused by the bacillus Mycobacterium tuberculosis, which is spread when people who are sick with TB expel bacteria into the air, for example by coughing. The disease typically affects the lungs, pulmonary TB, but can also affect other sites. Most people, about 90%, who develop the disease are adults, with more cases among men than women. About a quarter of the world's population has been infected with Mycobacterium tuberculosis. TB is curable and preventable. About 85% of people who develop TB disease can be successfully treated with a 6-month drug regimen, and regimens of 1 to 6 months can be used to treat TB infection. Some countries have already reduced their burden of TB disease to fewer than 10 cases and less than 1 death per 100,000 population per year. Research breakthroughs, for example a new vaccine, are needed to rapidly reduce the number of new cases each year worldwide to the levels already achieved in these low-burden countries. People with active TB can infect 5 to 15 other people through close contact over the course of a year. Without proper treatment, 45% of HIV-negative people with TB on average, and nearly all HIV-positive people with TB will die. Tuberculosis mostly affects adults in their most productive years. However, all age groups are at risk. TB occurs in every part of the world. Over 95% of cases and deaths are in developing countries. Of the 5.3 million people diagnosed with pulmonary TB worldwide in 2021, the WHO region with the highest percentage of new TB cases was the Americas, 79%, and the lowest was the Western Pacific, 56%. People who are infected with HIV are 18 times more likely to develop active TB. People with undernutrition are 3 times more at risk. Alcohol use disorder and tobacco smoking increase the risk of TB disease by a factor of 3.3 and 1.6 respectively. TB particularly affects poor and vulnerable populations. Refugees, IDPs and other populations in humanitarian settings are at increased risk of developing TB and having poor access to TB prevention and care services. Common symptoms of active lung TB are cough with sputum and blood at times, chest pains, weakness, weight loss, fever, and night sweats. Multidrug-resistant tuberculosis, MDR-TB, is a form of TB caused by bacteria that do not respond to the most effective first-line anti-TB drugs. MDR-TB is treatable and curable by using second-line drugs. However, second-line treatment options are limited and require extensive chemotherapy, up to 2 years of treatment, with medicines that are expensive and may have adverse drug reactions. Case study: rabies as an example of One Health economics, Namibia. Rauna Thingo, Ministry of Agriculture, Water and Forestry of Namibia. From 2015, we decided to implement a One Health approach to address rabies, especially in the northern part of the country, a hotspot with regard to rabies both in humans and animals. We wanted to apply the One Health approach to address the number of rabies cases in dogs, humans and livestock by changing the approach towards rabies control. This approach supports national health security by improving coordination, collaboration as well as communication at a human-animal environment interface to address the shared health threat of rabies. There had been a direct correlation between positive cases of rabies in dogs, humans and livestock, which negatively affects the communities. The rabies cases also leave some psychological trauma for the families. The number of visits at the hospital, the amount of money they have to spend, as well as the dog bites. Controlling rabies at its source, which is dogs, was cheaper than the application of post-exposure prophylaxis. If we empower the community to understand the danger of rabies, and that there is a control mechanism that is cheaper than getting post-exposure prophylaxis, it will help the Minister of Health and Public Health Service save on the cost of rabies.